Welcome to Nexus Clinical. Before diving into this lecture, I want to ensure we're all on the same page. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.
Welcome to this comprehensive overview of Digoxin, a crucial cardioactive steroid that has a narrow range of safe and effective doses. A thorough understanding of this medication is essential for safe patient management. This material aims to provide the necessary knowledge to navigate the complexities of digoxin's therapeutic uses and its potential for toxicity. In this content, we will explore the pharmacology of digoxin, including its mechanism of action on cardiac conduction and contractility. Digoxin interacts with the sodium-potassium ADPase pump, which results in increased strength of heart contractions and a slowing of the heart rate. We will also discuss common cardiac abnormalities caused by digitalis, such as sinus bradycardia, atrioventricular blocks, and ventricular arrhythmias, emphasizing their clinical importance. Furthermore, we will identify key factors that predispose patients to digitalis toxicity. These include advanced age, underlying heart disease, kidney problems, disturbances in electrolyte levels, and interactions with other medications. Recognizing these factors is vital for identifying patients at high risk. The role of potassium in digitalis toxicity will be examined, highlighting how high potassium levels can serve as a marker of severe toxicity in acute cases, whereas low potassium levels are often observed in chronic cases. Understanding these distinctions is important for effective treatment. We will differentiate between the presentation, diagnostic challenges, and clinical implications of acute versus chronic digitalis toxicity. Additionally, the review will cover the best treatment strategies for digoxin poisoning. This includes the primary use of digoxin-specific antibody fragments, their indications, dosing considerations, and supportive measures. We will also discuss the specific risks associated with administering calcium in this setting. By the end of this overview, you will be equipped to describe digoxin's effects on the heart, identify signs of toxicity, recognize predisposing factors, and implement appropriate treatment protocols to manage digitalis toxicity safely. Here are 10 brief learning objectives designed to guide a comprehensive understanding of the provided content on digoxin toxicity. First, describe the cellular and molecular mechanisms of digoxin's action, specifically its interaction with the sodium-potassium ADPase pump, which leads to increased intracellular calcium levels. This increase results in positive inotropic effects and negative chronotropic effects on the heart. Next, identify the common cardiac abnormalities caused by digitalis, including sinus bradycardia, atrioventricular block, and ventricular arrhythmias, along with understanding their underlying mechanisms. Additionally, determine the predisposing factors for digitalis toxicity. These include advanced age, underlying heart disease, renal insufficiency, particular electrolyte disturbances such as hypokalemia, hypomagnesemia, and hypercalcemia, as well as significant drug-drug interactions. Assess the role of potassium in this context by distinguishing hyperkalemia as a marker of severe acute poisoning from hypokalemia, which is often observed in chronic cases. Also, consider the implications of these electrolyte disturbances for patient management. Outline the key differences between acute and chronic digitalis toxicity, focusing on their typical onset, Clinical presentation, whether cardiac or non-cardiac symptoms and diagnostic considerations. Apply the best possible treatment strategies for digoxin toxicity. Recognize that digoxin-specific antibody fragments serve as the primary antidote in critical situations. Identify the specific indications for administering these antibody fragments, which include life-threatening arrhythmias, severe hyperkalemia, and hemodynamic instability. Explain the principles for calculating doses of digoxin-specific antibody fragments. This involves considering both the amount ingested and serum concentration measurements, along with understanding their limitations and the empirical dosing approaches commonly used. Describe essential supportive measures for managing digoxin toxicity. Emphasize the importance of correcting electrolyte imbalances and highlight that calcium salts should be avoided, as they can worsen intracellular calcium overload. Finally, recognize the clinical significance of digoxin's narrow therapeutic index. This highlights the importance of careful dosing and monitoring to prevent toxicity and ensure patient safety. Normal cardiac conduction involves the contraction of myocardial cells, which is regulated by various channels and proteins. During the depolarization of a heart muscle cell, voltage-gated calcium channels, specifically those known as calcium channels, open to allow calcium ions to enter the cell. This influx of calcium triggers the release of additional calcium ions from the sarcoplasmic reticulum, a specialized internal cell structure, through its ryanodine receptor. The fluctuations in calcium concentration within the cell link the process of depolarization with contraction and the process of repolarization with relaxation. Depolarization itself is initiated by the influx of sodium ions through sodium channels. This sodium entry causes the voltage-gated calcium channels to open, allowing calcium to flow down its concentration gradient into the cell. The influx of calcium then stimulates the release of even more calcium from the sarcoplasmic reticulum, with the amount released being proportional to the initial calcium influx and the amount of calcium stored within the sarcoplasmic reticulum. At rest, a protein called troponin prevents actin and myosin filaments from interacting. When calcium binds to troponin, this inhibition is removed, enabling actin and myosin to slide past each other, resulting in cell contraction. After contraction, calcium is actively removed from the cell to allow relaxation. The majority of calcium is pumped back into the sarcoplasmic reticulum where it binds to a protein called calsequestrin. This stored calcium is then readily available for release in subsequent depolarizations. Calcium removal from the cell is facilitated by several mechanisms. One involves the sarcoplasmic reticulum calcium pump, which is inhibited by a regulatory protein called phospholambin. The calcium-sodium exchanger transport protein exchanges 3 sodium ions from outside the cell for 1 calcium ion from inside, utilizing electrochemical gradients that usually favor sodium influx and calcium extrusion. This transporter operates passively but can reverse direction when intracellular sodium levels are high, extracellular calcium levels are high, or the cell membrane is depolarized. Additionally, some calcium is removed actively from the cell by a calcium ADPase pump. As intracellular calcium levels decrease, calcium dissociates from troponin, allowing the muscle cell to relax. Depolarization occurs after the opening of fast sodium channels, which causes an inward sodium current. The subsequent increase in intracellular potential opens voltage-dependent calcium channels, leading to calcium influx that induces the release of calcium from the sarcoplasmic reticulum, ultimately causing contraction. Repolarization begins after the contraction phase. It involves the active expulsion of sodium ions in exchange for potassium ions through an ADP-powered pump. This electrogenic pump, which exchanges 3 sodium ions for 2 potassium ions during each cycle, creates a sodium gradient that is used by the sodium-calcium exchanger to remove calcium from the cell. Meanwhile, the sarcoplasmic reticulum sequesters calcium through its own ADP-dependent pump, ensuring calcium availability for future contractions. Digitalis inhibits the sodium-potassium ATPase enzyme, leading to an increase in intracellular sodium levels. This prevents the sodium-calcium exchanger from expelling calcium in exchange for sodium. As a result, intracellular calcium levels rise, which enhances the strength of heart contractions through increased calcium release from the sarcoplasmic reticulum. In toxicology, excessive elevation of intracellular calcium can raise the resting potential of cardiac cells. This phenomenon can cause increased sensitivity of the myocardium and predispose individuals to abnormal heart rhythms, known as dysrhythmias. Digoxin is a cardiac glycoside that impacts the heart by directly interacting with sodium-potassium ADPase pumps located on the external membranes of heart muscle cells. Its primary action is to reversibly inhibit these pumps, which are essential for maintaining the balance of sodium and potassium ions across cell membranes. When these pumps are inhibited, sodium is prevented from being pumped out of the cell, leading to an increase in the intracellular sodium concentration. The elevated sodium levels inside the cell influence another important mechanism, the sodium-calcium exchanger. Under normal circumstances, this exchanger removes calcium from the cell in exchange for sodium. However, with increased intracellular sodium, this process is reversed, causing calcium to flow into the cell. This influx of calcium is taken up by the sarcoplasmic reticulum, an organelle within muscle cells responsible for storing calcium. During muscle contraction, the sarcoplasmic reticulum releases this stored calcium, which enhances the interaction between contractile proteins. As a result, the force of heart muscle contractions is increased, leading to a stronger heartbeat. The effects on cardiac function include an increase in the force of heart contractions, which is referred to as a positive inotropic effect. This heightened contractility enhances the systolic function of the left ventricle, meaning the heart is able to pump a greater volume of blood with each beat. As a result, circulation improves, supporting better overall cardiovascular health. Digoxin exerts a negative chronotropic effect by slowing the heart rate through multiple mechanisms. It acts similarly to the parasympathetic nervous system, which is responsible for reducing heart rate. Specifically, digoxin influences the sinoatrial and atrioventricular nodes, both of which are responsible for generating and transmitting electrical impulses in the heart. Additionally, digoxin stimulates the vagus nerve, a major component of the parasympathetic nervous system, which further contributes to the slowing of the heart rate. It also decreases the levels of norepinephrine, a neurotransmitter that increases heart rate, thereby shifting the balance of the autonomic nervous system towards parasympathetic dominance. This combined effect results in a decreased heart rate. The combination of these effects makes digoxin a valuable medication for treating conditions such as heart failure and irregular heart rhythms. It works by strengthening the contractions of the heart muscle, which enhances blood flow throughout the body. Additionally, digoxin helps regulate abnormal heart rhythms, contributing to overall cardiac stability. However, it is important to administer this medication with caution, as it has a narrow therapeutic index. This means that the dosage must be carefully monitored to prevent toxicity and ensure safe and effective treatment. Digitalis can induce various cardiac abnormalities, with the three most common being sinus bradycardia, atrioventricular block, and ventricular ectopic beats or tachycardia. Sinus bradycardia is the most frequent cardiac abnormality caused by digitalis. It occurs when the heart rate drops below 60 beats per minute. This condition results from digitalis enhancing vagal activation, which slows down the natural pacemaker activity of the sinoatrial node. The effect is more significant at higher doses or in individuals with pre-existing conditions that predispose them to slower heart rhythms. Atrioventricular block is a condition where the electrical signals from the upper chambers of the heart, the atria, to the lower chambers, the ventricles, are delayed or blocked. Digitalis can exacerbate pre-existing atrioventricular blocks and may induce them at higher doses. This occurs because digitalis directly slows conduction through the atrioventricular node, leading to varying degrees of block. Ventricular ectopic beats and tachycardia refer to abnormal early beats or rapid rhythms originating from the ventricles. Toxic levels of digitalis can increase automaticity within the ventricular myocardium, causing extra beats or sustained rapid rhythms, which can be life-threatening, especially in individuals with underlying heart disease. The three primary factors that predispose individuals to digitalis toxicity are advanced age, decreased renal function, and the presence of underlying cardiac diseases. Older adults are more vulnerable to digitalis toxicity due to changes in how their bodies process medications as they age. These changes include a decline in kidney function and alterations in how drugs are metabolized. As kidney function tends to decline with age, the elimination of digoxin, a common digitalis medication, becomes less efficient. This inefficiency can lead to the accumulation of the drug in the body, increasing the risk of toxicity. Additionally, elderly individuals often have a higher prevalence of underlying heart conditions and are more likely to be on multiple medications. These factors can interact with digoxin, further elevating the risk of adverse effects and toxicity. Underlying cardiac disease can significantly influence a patient's response to digitalis. Patients who have pre-existing heart conditions such as heart failure or irregular heart rhythms like atrial fibrillation are typically more sensitive to the effects of digitalis. As a result, they are at a higher risk of developing toxicity from this medication. These cardiac conditions often involve changes in the electrical activity of the heart and impaired heart function, which can make the heart more susceptible to irregular rhythms caused by digitalis. Additionally, patients with heart disease are frequently taking multiple medications. Some of these drugs can increase the levels of digitalis in the body or amplify its toxic effects, further elevating the risk. Renal insufficiency, which refers to impaired kidney function, significantly increases the risk of digitalis toxicity. The medication digoxin is mainly excreted through the kidneys, so any decline in renal function can lead to a buildup of the drug in the bloodstream. This accumulation heightens the likelihood of toxicity. Renal insufficiency can be either acute, resulting from conditions such as dehydration or infections, or chronic, as seen in patients with long-standing kidney disease. Regardless of the underlying cause, impaired kidney function requires careful dosing and vigilant monitoring of digoxin to prevent the development of toxicity. Other factors can contribute to digitalis toxicity. Electrolyte disturbances such as low potassium levels, low magnesium levels, and high calcium levels can enhance the effects of digitalis and lead to toxicity. These imbalances change the transmembrane potential of cardiac cells, making them more vulnerable to the arrhythmogenic effects of digoxin. Additionally, interactions with certain medications can increase the risk. Drugs like macrolide antibiotics, quinidine, verapamil, amiodarone, and some diuretics may interfere with the absorption, metabolism, or excretion of digoxin, thus raising its levels in the blood and increasing the likelihood of toxicity. Hypothyroidism is another contributing factor. This condition can reduce the clearance of digoxin from the body, resulting in higher serum levels and a greater risk of adverse effects. Acute digitalis poisoning typically occurs when a person accidentally or intentionally ingests a large dose of digoxin in a single instance. Symptoms generally begin within 6 hours of ingestion, although there may be an asymptomatic period lasting from several minutes to a few hours. In some cases, life-threatening symptoms can be delayed because of the slow distribution of digitalis into tissues. The level of digoxin in the blood, along with the patient's symptoms, medical history, and potassium levels, are important for assessment. Acute toxicity is often determined more accurately by potassium levels rather than digoxin levels alone. It is essential to understand that no single serum digoxin concentration can definitively confirm or exclude toxicity, as various factors influence these levels. The typical therapeutic range for serum digoxin concentration is between 0.5 and 2.0 nanograms per milliliter, but some experts suggest that keeping levels at or below 1.0 nanogram per milliliter may better balance benefits and risks. To convert digoxin levels between nanograms per milliliter and millimoles per liter, multiply the level in millimoles by 0.781 to get nanograms per milliliter. Conversely, Dividing the nanogram per milliliter value by 0.781 converts it to millimoles per liter. For example, a patient with a digoxin level of 2.0 nanograms per milliliter would have approximately 2.56 millimoles per liter, which is calculated by dividing 2.0 by 0.781. Patients with acute toxicity may present with symptoms that are not cardiac in nature. Cardiac symptoms and changes on electrocardiogram include sinus bradycardia, which is the most common abnormality, atrial tachycardia, accelerated junctional rhythms, vesicular tachycardia, premature contractions originating from junctional or ventricular sites, sinoatrial block, and atrioventricular blocks of all degrees. Other potential cardiac disturbances include junctional tachycardia, sinus arrest, and exit block, as well as ventricular ectopic beats and tachycardias. In some cases, there may be irregular bradycardia, often seen in chronic poisoning, involving a combination of atrial fibrillation and conduction disturbances. Severe arrhythmias such as third-degree atrioventricular block, ventricular tachycardia, and ventricular fibrillation are considered life-threatening. Electrolyte abnormalities are also common during poisoning. Hyperkalemia, or elevated serum potassium levels, frequently occurs in acute poisoning cases. Serum potassium levels serve as a predictor of mortality better than initial electrocardiogram changes or serum digitalis concentration. For instance, a serum potassium level below 5 milliequivalents per liter has been associated with a 50% mortality rate in patients with acute digitoxin poisoning. Additionally, hypomagnesemia, or low magnesium levels, may contribute more frequently to digoxin toxicity than low potassium levels, as it increases the risk associated with digitalis. Chronic toxicity presents a greater diagnostic challenge compared to acute toxicity. Its symptoms are often nonspecific and can overlap with those of other common conditions in elderly patients, such as heart disease and various chronic illnesses. This form of toxicity is more frequent than acute poisoning and typically occurs in patients suffering from cardiac diseases and kidney failure. It can also result from interactions between medications or changes in how the body absorbs or eliminates drugs. Older adults are more susceptible to chronic toxicity, which is often difficult to diagnose because it develops insidiously and exhibits a wide range of symptoms that may be less obvious than those seen in acute poisoning. In cases of digoxin toxicity, blood serum levels are essential for confirming the diagnosis in both acute and chronic situations. While levels above the therapeutic range of 0.5 to 2 nanograms per milliliter could indicate toxicity, these levels do not always directly correlate with clinical symptoms, particularly in chronic cases. Interpreting serum digoxin levels requires consideration of additional factors, such as the timing of blood sample collection relative to medication ingestion in acute cases and the presence of other medical conditions. Chronic toxicity develops gradually as digoxin accumulates in patients, especially those with cardiac conditions or renal impairment. It can also occur due to drug interactions or physiological changes affecting digoxin clearance. The clinical presentation includes gastrointestinal symptoms such as nausea, vomiting, abdominal pain, diarrhea, loss of appetite, and weight loss. Neurological symptoms may include fatigue, weakness, lethargy, confusion, drowsiness, headache, hallucinations, delirium, psychiatric disturbances, and rarely seizures. Visual disturbances are also common, including blurred vision, blind spots, sensitivity to light, seeing flashes of light, decreased visual sharpness, color vision abnormalities, and seeing yellow halos around lights. Additionally, some patients may experience other rare complications like mesenteric ischemia. It is also important to note that hypokalemia, or low potassium levels, is more frequently observed in patients with chronic digitalis toxicity. Patients with hypokalemia tend to have lower serum digoxin concentrations compared to those with normal potassium levels, and sometimes repletion of potassium can correct abnormal heart rhythms without significant changes in serum digoxin levels. Hyperkalemia plays a crucial role in the treatment of digoxin overdose because it serves as both a symptom of severe toxicity and a factor that influences the effectiveness of the primary treatment using anti-digoxin antibody fragments. Elevated serum potassium levels, specifically above 4.5 millimoles per liter, are considered significant in this context. When serum potassium exceeds 5 millimoles per liter during acute digoxin poisoning, it strongly indicates the need to administer anti-digoxin antibody fragments. The level of hyperkalemia often reflects the severity of digoxin toxicity. In patients who experience acute poisoning, hyperkalemia is usually a hallmark of severe toxicity. In contrast, in chronic cases, hyperkalemia is often associated with other underlying health conditions or the use of certain medications. Monitoring serum potassium levels is therefore essential in assessing the severity of poisoning and guiding treatment decisions. The primary treatment for a digoxin overdose accompanied by elevated potassium levels is the administration of anti-digoxin fragments. This antidote should be administered promptly to counteract the toxic effects of digoxin and to prevent further increases in potassium levels. In cases where hyperkalemia is severe, with potassium levels exceeding 5.6 millimoles per liter, temporary measures can be used to lower potassium levels before or alongside the administration of the antidote. These measures include the use of glucose with insulin, sodium bicarbonate, and sodium polystyrene sulfonate. It is important to avoid the use of calcium salts in this context. Although calcium salts are typically employed to manage hyperkalemia, they should be avoided in cases of digoxin toxicity, as calcium can worsen the toxic effects by increasing intracellular calcium levels. This can potentially lead to dangerous heart rhythm disturbances. Close monitoring of potassium levels is paramount to ensure timely correction of hypokalemia if it develops following Fab fragment treatment. The risks associated with administering calcium in cases of hyperkalemia caused by digitalis toxicity are significant. Digitalis toxicity, a condition that results from a use of digitalis drugs, involves a complex mechanism that includes calcium loading of heart muscle cells. When digitalis is administered in such cases, it can be potentially dangerous. Digitalis works by inhibiting the sodium-potassium ADPase pump, an essential enzyme in cell function. This inhibition causes an accumulation of sodium inside the heart muscle cells. Normally, sodium is exchanged for calcium through a specific cellular mechanism. However, the increased sodium levels disrupt this exchange process, preventing calcium from being expelled from the cells efficiently. As a result, there is an overload of calcium within the heart cells. This excess calcium contributes to the toxic effects associated with digitalis, notably including the predisposition to abnormal heart rhythms, known as arrhythmias. Therefore, administering calcium salts in patients with digitalis-induced hyperkalemia can exacerbate these toxic effects and should be approached with caution. Giving calcium salts to a patient experiencing digitalis toxicity can worsen the condition by further increasing intracellular calcium levels. This escalation may lead to more severe arrhythmias such as irregular heartbeats and can impair heart function, potentially causing hypercontractility or even a state known as stone heart hypocontractility. In extreme cases, this may result in cardiac arrest. Some might argue that the rate at which calcium is administered could influence the severity of adverse effects. However, many experts recommend avoiding calcium altogether in cases of digitalis toxicity. Safer and more effective alternatives for treating hyperkalemia caused by digitalis poisoning include digoxin-specific antibody fragments, which directly neutralize the toxin and reverse its effects, including elevated potassium levels in the blood. Other treatments involve the use of insulin and glucose, which work together to move potassium into cells, thereby lowering serum potassium levels. Sodium bicarbonate can also be used to shift potassium intracellularly and to correct acidosis. Despite these theoretical risks, a review of 23 patients who received calcium during digitalis toxicity showed no cases of life-threatening dysrhythmias, no increase in mortality rates, and no evidence of decreased chances of survival. This suggests that while caution is advised, calcium administration in this context may not be as hazardous as previously thought. The primary treatment for both acute and chronic digoxin toxicity involves the use of digoxin-specific antibody fragments, commonly known as Fab fragments. These antibodies bind to digoxin in the bloodstream, preventing it from interacting with its target tissues and thereby reversing its toxic effects. Once bound, the Fab fragments, along with digoxin, are excreted by the kidneys. Fab fragments are effective in resolving both cardiac and non-cardiac manifestations of digoxin toxicity. They are useful in managing poisoning from digoxin, as well as from other related substances such as digitoxin, linaticide C, and various cardiac glycosides found in plants like oleander, foxglove, and lily of the valley. Additionally, they can be used in cases involving venomous bites from certain animals. The administration of Fab fragments early in the course of poisoning, even in patients showing only mild symptoms but who have poor prognostic factors, can significantly reduce the risk of death. However, it is important to note that Fab fragments can cause a rapid decrease in serum potassium levels, especially in patients who initially present with high potassium levels due to digoxin toxicity. Therefore, close monitoring of potassium levels during and after treatment is essential, and correcting abnormal potassium levels is crucial. Overall, Fab fragments are a vital treatment option and have proven effective in reversing the toxic effects of digoxin and related compounds, improving patient outcomes. The decision to administer Fab fragments should be based on the patient's clinical presentation and the severity of their digoxin toxicity. These fragments are generally indicated in patients experiencing life-threatening tachyarrhythmias or bradyarrhythmias, or in those with hyperkalemia greater than 6 millimoles per liter. They are also recommended for patients with hemodynamic instability, elevated digoxin concentrations exceeding 2 nanograms per milliliter or 2.6 nanomoles per liter, or in cases of acute psychosis characterized by severe agitation, delusional thinking, and assaultive behavior. Additionally, Fab fragments are appropriate for patients with rapidly progressing toxicity or those at high risk for life-threatening digoxin toxicity, even if initially only mildly symptomatic. Anti-digoxin Fab fragments work by binding to free digoxin in the bloodstream, preventing it from attaching to its target, the sodium-potassium ADPase pump. This binding reverses the toxic effects of digoxin and helps the body eliminate the drug. However, administering these Fab fragments can also worsen hypokalemia. This occurs because the Fab digoxin complexes are mainly eliminated through the kidneys. As these complexes are filtered and excreted, potassium can be lost along with them, potentially leading to a rapid decrease in serum potassium levels. Therefore, it is crucial to carefully monitor potassium levels during and after the administration of Fab fragments. Ensuring that potassium levels are corrected before starting treatment is essential to avoid severe hypokalemia, particularly in patients who initially present with high potassium levels. The goal is to administer a dose of Fab fragments that can bind to and neutralize the amount of digoxin in the body. Two main approaches are described in the procedure. The first approach involves calculating the dose based on the ingested amount of the substance. If the amount and type of digitalis ingested are known, the body load can be estimated using a specific formula. This formula multiplies the ingested amount of digitalis by its bioavailability to determine the total body load in milligrams. For example, the bioavailability is 0.6 for digoxin and 1.0 for digitoxin. To find the number of 40 milligram vials of DG-Fab needed, the calculated body load is divided by 0.5, since each vial can bind approximately 0.5 milligrams of digoxin. There are limitations to this approach. Often, the amount of digitalis ingested is unknown or unreliable, especially in cases of accidental ingestion or intentional overdose, where the patient might not be able to provide accurate information. Additionally, this calculation assumes complete absorption of the ingested dose, but this may not be the case due to factors such as vomiting, gastric emptying, or the use of activated charcoal. The bioavailability of digoxin can also vary depending on individual factors, the formulation of the ingested product, and the presence of other substances in the gastrointestinal tract. The calculation based on serum digoxin concentration involves estimating the body load of the drug using a specific formula. If the steady-state serum concentration of digoxin is known, the body load can be calculated by multiplying the serum glycoside concentration by the volume of distribution of the drug and the patient's weight, then dividing the result by a constant. This constant varies depending on the specific glycoside. For digoxin, it is 5.61 liters per kilogram, and for digitoxin, it is 0.56 liters per kilogram. The number of vials required to administer the drug is then determined by dividing the calculated body load by 0.5. However, there are several limitations to this calculation. It assumes that the serum digoxin concentration accurately reflects the total body burden of the drug. This assumption holds true only after the drug has reached equilibrium between the blood and tissue compartments, a process that can take several hours, especially in the case of digoxin. Furthermore, the volume of distribution can vary depending on factors such as age, renal function, and underlying medical conditions. Additionally, using the steady-state serum concentration may not be appropriate in cases of acute toxicity, as the drug may still be in the distribution phase and have not yet reached equilibrium. Given the limitations of the previous calculations, some sources recommend using empirical dosing regimens based on the clinical presentation and the suspected severity of the poisoning. For adults with acute ingestion, recommended doses vary widely, ranging from 2 to 4 vials up to 10 to 20 vials. In pediatric patients experiencing acute poisoning, the typical empirical dose is between 400 and 800 milligrams, equivalent to 10 to 20 vials. These varied recommendations underscore the importance of careful clinical judgment when determining the initial dose. Recent research and clinical experience suggest that lower initial doses of Fab fragments may be sufficient, even in cases of acute toxicity. An initial dose of 80 milligrams, which corresponds to 2 vials, is often recommended for treating acute poisoning. This dose can be repeated if necessary, allowing for treatment adjustments based on the patient's clinical response. Such an approach aims to balance the effectiveness of treatment with the potential risks and costs associated with higher doses. Close monitoring of the patient is essential, and additional doses should be administered as needed, depending on the patient's condition. Supportive measures are an essential part of managing digoxin toxicity, in addition to the use of Fab fragments. These measures include correcting electrolyte imbalances, particularly low levels of potassium and magnesium, which can exacerbate toxicity. Proper management of cardiac arrhythmias with appropriate medications is also crucial. Additionally, providing support to stabilize hemodynamics may be necessary depending on the patient's condition. It is important to avoid calcium salts in this context, as they can worsen digoxin toxicity by increasing the levels of calcium inside cells. For decontamination of the gastrointestinal tract in cases of acute poisoning, activated charcoal can be administered within 2 hours of ingestion. However, its effectiveness is limited because digoxin is absorbed quickly, reducing the window for effective intervention. Digitalis toxicity can occur due to both acute and chronic exposure to digitalis compounds. Acute toxicity generally happens after accidental or intentional ingestion of a large dose of digitalis, with symptoms typically appearing within 6 hours. Chronic toxicity, which is more common, develops gradually in patients who are long-term users of digitalis. Factors such as kidney problems, drug interactions, and changes in how the body absorbs or eliminates digitalis can contribute to this condition. The most common plant sources of digitalis include foxglove, oleander, and yellow oleander. The symptoms of digitalis toxicity are primarily gastrointestinal, neurological, and visual. Patients may experience nausea, vomiting, fatigue, confusion, blurred vision, and alterations in color perception. Cardiac symptoms involve various heart rhythm disturbances, with sinus bradycardia, or a slow heart rate, being the most frequent. Other potentially life-threatening rhythm disturbances can also occur. In cases of acute poisoning, hyperkalemia or high potassium levels is a common and serious finding, and is considered a strong predictor of mortality. Diagnosis involves taking a thorough patient history, evaluating symptoms, and performing an electrocardiogram. Measuring serum digoxin levels can be helpful, but does not always provide definitive results. Management focuses on supportive care and addressing any life-threatening complications. This includes correcting electrolyte imbalances and treating abnormal heart rhythms. The primary antidote for severe digitalis poisoning is digoxin-specific antibody fragments. These antibodies bind to digitalis in the bloodstream, neutralizing its toxic effects. They are highly effective in reversing toxicity and are indicated for life-threatening arrhythmias, elevated potassium levels, and unstable blood circulation caused by digitalis poisoning. The dosage of these antibody fragments depends on the severity of the poisoning. Recurrent toxicity may occur after treatment, especially in patients with kidney failure, making ongoing monitoring for symptoms crucial. Elderly individuals are at higher risk of digitalis toxicity due to age-related physiological changes and declining kidney function. It is essential for healthcare providers to be aware of the potential for digitalis toxicity in patients taking these medications. Early recognition and prompt treatment can significantly improve patient outcomes.
This was an episode of the Nexus Clinical Podcast. This is for general informational purposes only and does not constitute the practice of medicine, nursing, or other professional healthcare services, including the giving of medical advice. No doctor-patient or pharmacist-patient relationship is formed. Using this information and the materials linked to this content is at the user's risk. This is not intended to substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay seeking medical advice for any medical condition they have, and they should consult their healthcare professionals for any such conditions. Clinical experts created the references, content, and clinical insight. NotebookLM, a Google AI tool, created the content, which I extensively reviewed before release. Finally, the host states that he takes all conflicts of interest seriously. Currently, there are no conflicts to disclose. For all of his disclosures and the companies he invests in or advises, he directs users to reach out independently, where he keeps an up-to-date and active list of all disclosures.